We'll now have Dr. Sujatha Mohan talking to us about using a piggyback IOL for treating of a refractive surprise.
So good morning, everybody. At the outset, I'd like to thank Nitin for giving me this opportunity. Once again, we have been doing this course for the past 4 or 5 years. And I'd like to thank AIOS and APAO for giving this opportunity to us. Pardon? No, there's no audio. Is it coming? Sorry. I have to go to the first slide. Okay. Okay. So my topic is I missed the bullseye. So I'm going to show you a series of cases. This was a 57-year-old female with an immature cataract, and she had a cylinder of minus 4.5. You can see she has a clear case of pellucid marginal degeneration, has a 6.7 diopter cylinder, and topography is showing a 7.7 cylinder. So we did the calculation based on the Barrett's calculation, and we ordered for a customized toric IOL. And you can see that the recommended placement is somewhere around 150 or something. And so the lens was placed in that axis, but the post-operatively, she came up with a minus 7 cylinder. From minus 5, she went into minus 7 cylinder. So what do we do in this case? She's a case of pellucid, and she's already been using contact lens. The wiser decision would have been to just put a non-toric lens and just ask her to continue to wear her lens. So, but since we've already placed a toric, we decided to go use a Zalvida toric caliper tool to calculate the angle of difference in the degrees and measure whether the intended meridian from the toric alignment, which is already present. And so we did get a different. You can see it is almost at 90 degrees, which is surprising because her cylinder actually is showing around 150 degrees. So this is what we did. In a week's time, we rotated the lens. It's a custom toric lens made by Ocare, no financial interest. But they're quite easy to rotate. It's important that you put enough viscoelastic because you don't want to rupture the bag. And so just gently, if you take a longer time, then some fibrosis would have formed. But since we did it within a week's time, it was quite easy to rotate. And once we rotated into position, you can see that I'm using actually a Callisto, and this I usually mark even if I use a Callisto because sometimes the Callisto doesn't show up very clearly, or it can just stop in between, which has happened to me once. So so you can see the Callisto is also showing that it's in a good position. So post-operatively, she did well. She had a very small minus 2 cylinder. So in case of residual uncorrected refractive cylinder, you repeat all the pre-op tests, IOL master, lens trace, do an eye trace. Special formulas like Barrett, TrueK, Kane or EVO formulas can be used. Check your topography and pentacam, dilate and check the position of the IOL, redo the calculation. High incidence of errors and abnormal corneas. So it's better to they go back to their contact lenses, but that gives them the best quality of vision. So again, a case 2 is a post-RK case with an immature cataract. The problem is with RK is the IOL power calculation. You can see a conventional method is showing a 17.5, whereas calculation by Barrett's is showing a maximum of 21. You have to anticipate a hyperopic shift in these patients, and you have to explain to them that's a possibility because all the refractive surgery patients, they expect a plano, like what they had immediately after refractive surgery. And another problem with post-phaco cataract surgery is that the incisions can open up. So whatever you do, make sure that you have low flow parameters. Don't increase the bottle height too much. And if you're a good phaco surgeon, you can go ahead with any method that you want to. And placing the incision is also very important. Place the incision at the limbus. in between the two RK incisions, so that you don't open up the incisions. Otherwise, you can even make a conjunctival opening and do a scleral opening. So then now in this case, fortunately, I do have cases where it is opened up, and in this case, fortunately, everything went well, and the lens was implanted in the bag, and she did extremely well. So she had a minus 1.75 cylinder at the end of the procedure. So the problems is biometry is the main bugbear. RK wound gaping has to be taken into consideration, and most of these patients have to be advised about the hyperopic shift. So third one is a hyperopic classic patient, was very keen on multifocals. You can see a very centered ablation. This is what comes up when you do a hyperopic ablation. Most of them show up as keratoconus because it's a hyperprolate cornea. But you can see it's a very well-centered ablation. So we decided to use a Barrett's formula as well as a Hill RBF formula, which more or less synchronized, and we went ahead and did a multifocal IOL for her. And she did very well. She had a 6x6 and 6 vision. Multifocal IOLs, most important point is well-centered topography, IOL master, Barrett's formula. There are a lot of newer formulas like Hill RBF, and more importantly, a good counseling is very important. Do not attempt to do multifocal IOLs if you have a decentered ablation like this. So next is again a patient who had a myopic classic with improving to 6.9 minus 2.5. You can see she has a mild decentered ablation, and the maximum power to be implanted was 20 diopters, and that's what we did, and the axis was 110 degrees. And you can see the post implantation, the placement is exactly where we desired. And post-operatively, again, she had a minus 2 cylinder. And in this patient, so we decided to do, because the cylinder was very small, we decided to do a bioptics and did a laser to correct her minimal astigmatism after a period, waiting for a period of 3 months. So this is some of the post-op things that we did. So the options are bioptics, Wavefront optimized PRK, Contura vision can be done. This is a case of high myopia with a residual cylinder of 2.5, and which we did a rotation just similar to what I showed you. So I'm just skipping this video. So case 6 was a high residual myopia. The options in this case was, because this was actually referred to us with a minus 7 diopter cylinder, probably because of the wrong IOL placed. So the options were PRK or an IOL exchange with proper power IOL. The third option is a sulcoflex IOL in the sulcus to correct the residual power. The power calculation can be done like this. If you have a hyperopic error, you multiply it by 1.5. If you have a myopic error, you can multiply it by 1.3 to get the IOL power for hemetropia. So the sulcoflex lenses are made by a company called Rayner, which probably is a monopoly. And so they are specifically made to be placed in the sulcus. So they have a concave posterior surface and a convex anterior surface. So it protects the lens from touching the other lens, and it can be implanted into the sulcus very effectively. And like I said, once we do that, it corrects the power, and it's quite a simple method of correcting the residual power. See, if it is somewhere around minus 2 or minus 3, you can still do a laser. But when it is minus 7, you can, the sulcoflex IOL is a good option. You can even think of phakic IOL as an option for these patients who have higher residual errors. And this goes in very nicely, and the patient had a very good outcome. So a little bit points about sulcoflex IOL. It's a hydrophilic IOL with a 6.5 millimeter optic and 13.5 overall length. It has a concave, like I told you, it's got a concave posterior surface and convex anterior surface with a 10-degree posterior angulation. That is very important. That ensures the separation of the IOL from the iris anteriorly and the primary IOL posteriorly to prevent iris chafing. So refractive surprises can happen after post-LASIK PRK. You can get it in ectatic corneas, vitrectomy with silicone oil. So you can use newer formulas like Barrett's, Hill, RBF, Kane formula. Importantly, you have to do a topography and tomography in all these patients. Management can be IOL rotation, explantation and reimplantation, sulcoflex IOLs, and phakic IOLs to achieve your emetropia. Thank you.